Thank you all. We now move on to our CME on challenges of OBGY practice. Knowledge needs to be updated periodically and doors of knowledge cannot be closed. Every case in our field poses a new challenge and urges us to think of newer solutions. Getting updated is utmost important in this era where medical field is progressing rapidly. So today we have a team of esteemed speakers to guide us on various topics. First of all, I would like to invite the chairperson for today's session, Dr. Madhuri Dabde Madam and Dr. Raghoji Madam.
Dr. Madhuri Dabde Madam, she is a OBGYN consultant practicing since 30 years at Krishnamai Nursing Home, past president SOGS, Best Society Award at national and state level during tenure of her presidency. Received many awards in her credit like Sri Ratna Puraskar, Lions Club Agrani Puraskar, Sharat Pratishthan Puraskar and so many. Dr. Raghoji Jyotirmay Madam, she is director at Raghoji ENT and Maternity Hospital, practicing in Solapur OBGYN practice since 25 years. She has special interest in sonography and fetal medicine. Over to you, chairpersons, to start the session.
Good evening. On behalf of all the ladies of SOGS, I thank our dynamic president, Dr. Virkar, for felicitating us and for the wonderful crowd and making us to feel as a queen. Thank you. Now we will move towards our academic session. Our first speaker is Dr. Rohan Palshetkar. He is a chairperson, Foxy Young Talent Promotion Committee, and he is a professor at D.Y. Patil School of Medicine and head of Reproductive Medicine Fellowship Program in the same college. He has multiple publications in national and international journals. Foxy, he is a Foxy Future Awardee, AMOX, V for Stree Puraskar Awardee, Foxy Korean Shanti Yadav, Kumud Tamaskar and late Praveen Mehta Awardee, Foxy Future Awardee 2019-20.
Thank you, madam. Thank you so much. Thank you so much for the kind introduction. At the outset, I want to thank the Solapur OBGY Society for having me here. And today I'm going to be talking about medical management of fibroids. See, when we talk about fibroids, our first concept is to try and go in for surgery. But that itself also has a few complications, and in certain cases, we may have patients which may not be even fit for surgery. So how can we overcome that? So let's look at the three dilemmas. One is diagnosis, the other is treatment, and the psychosocial dilemma. See, most of these patients come with abnormal uterine bleeding, and it's one of the most frequently disabling symptoms of uterine fibroids. If you go to see, the undiagnosed bleeding symptoms generally go from 15% to almost 25% across 5 countries. Over 9 to 33% of these patients try and delay their treatment for 5 years before they go in for treatment. And then there is a psychosocial dilemma which basically says that there's been this study which shows that because of abnormal uterine bleeding, there's an absenteeism rate of 33%, productivity was affected by 37%, and activity was impaired by 38%. So now when we look at it, if we go to see within 12 months of diagnosis, almost 45% of the patients were undergoing some sort of surgical procedure. If you go to see, almost 30% were undergoing a hysterectomy, about 6% underwent a myomectomy, other surgical procedures were about 15 to 16%, GnRH agonists, that's where your medical management comes in, combined oral contraceptives in about 18%, and other medications was about 12%. So what is the economic burden? Now see, when we look at the economic burden, this is a study from the US. Now the thing is, there's a lot of insurance, that even in the US you can see, and UK you can see that the costs are almost 3 times annual. There the government is generally has the burden of cost on the healthcare. 3 more times of the disability claims, 6 more times that the patient had to be admitted more than once. If you see, there's a 35% greater utilization of surgical procedures and in almost a 50 times chance greater rate of having a hysterectomy. So if you see, the total costs are almost 12,000 to 25,000. Now if you equate that to Indian standards and you look at what would be the cost, understand that yes, we are currently moving towards the insurance based practice, but there are still quite a majority of patients who may not have insurance, and their costs do end up increasing and having an economic burden on themselves. Sorry. So what are the current surgical and non-surgical management strategies for myomas? If you go to see, first is your hysterectomy, then you have your myomectomy which is available, then you have your hysteroscopic myomectomy for your submucous myomas, then you have your MRG-FUS, and you have uterine artery embolization. Now there's always been a battle between the infertility specialists as well as the laparoscopic surgeons. If you look at the infertility specialists, they'll always say that you don't need to remove a fibroid unless it's indenting the cavity, while the laparoscopic surgeons may differ in their opinion. Bhaskar sir, I'm not arguing with you on most of the cases over here. But if you see, there was this battle which happened in 2021, and then the final editorial came by Jacques Donez. Jacques Donez has been someone who's been talking in the field of laparoscopy and more endometriosis for a much longer period of time. What he said was, maintaining fertility is an important goal in the management of asymptomatic uterine fibroids. And for women wishing to preserve their fertility, SPRMs, that's the selective progesterone receptor modulators, have provided a good alternative. And one particular drug, uripristal acetate, was recommended in the algorithms for patients with fibroids who want to remain fertile. Unfortunately, the Pharmacovigilance Risk Assessment Committee of the European Medical Agency has limited use to restricted indication. Now, we obviously know that there was a major issue about uripristal in the past, but I'll be addressing that as we go on in the talk. So what is the unmet medical need of uterine fibroids? See, what do patients expect? Well, number one, they don't want to have invasive surgery. Number two, almost half of them want to preserve their uterus. And number three, they want to preserve their fertility. So how do we approach this unmet needs? Currently, there are only 2 drugs which are approved in India by DCGI, that is the GnRH agonist as well as the SPRMs. If you look at the GnRH agonist, the drug works only at the pituitary. Basically, what it's doing is downregulation and desensitizing the GnRH receptors, and it's producing a hypogonadotropic state. But when you looked at the selective progesterone receptor modulators, it's acting on the fibroids directly by inhibiting the cell proliferation. It acts on the endometriums by stopping the uterine bleeding, and it also results in benign and reversible changes in the endometrial tissue. And in the pituitary, it inhibits ovulation and maintains follicular phase levels of estradiol. So this paper, which was basically published by Jeffrey Jensen, this was back now in 2020. It was basically talking about uripristal being the Swiss Army knife of hormonal treatment. They have these studies about the Pearl 1 and Pearl 2 studies. I'm not going to go into too much detail into that, but it could be seen that patients who took uripristal acetate, especially patients with fibroids and suffering from menorrhagia, they saw that when you gave uripristal acetate as well as supplemented with iron, the hemoglobin rose better with patients taking almost 10 milligrams of iron, but even 5 milligrams seem to have similar rates. If you looked at the volume reduction, you can see that uripristal acetate had similar results in volume reduction of fibroids as compared to GnRH depot as well. Safety profile is something that was, if you could see, has a major difference when you look at the agonist and the SPRMs. With GnRH agonist, you could see that the hot flushes were more. This is because with GnRH agonist, the estradiol levels drop down to less than 30, and this can cause like a menopausal state in the woman even though it's temporary. Bone resorption is also minimal with SPRMs as compared to GnRH agonists, where we do know that eventually sometimes if you're looking at long-term medication, you do end up having to give add-back therapy as well. Now, what is the treatment algorithm when we look at using for fibroids? If you look at fibroids, when you have type 0 myomas, that's in the endometrial cavity itself, hysteroscopic myomectomy is the most appropriate approach. There's no concept of medical management at all. If you look at treatment of type 1 myomas, it depends on the myoma size, presence of the anemia, and the surgeon skill. I think the step W classification which is there is quite clear on telling you which cases can be managed in one sitting and which could be requiring 2 sittings. In medical therapy with ulipristal acetate, type 1 myomas respond to the ulipristal acetate, they regress in size, and sometimes if the volume decreases to a point where they're not becoming submucosal anymore, it can be considered that the surgery may not be required. Remember one thing, ulipristal is not a pre-op indication. It is not something that you should give to reduce the size thinking it will be easier to operate. It needs to be reserved for patients who can't undergo surgery or unfit for surgery. Now, if you look at the treatment algorithm for type 2 or type 5 myomas, that's single or multiple with distorting the uterine cavity, if the patient is desiring of pregnancy, you can give 2 courses of approximately 3 months each with SPRMs. If there's a very good response, you can, where the volume reduction is more than 50% and it's no longer distorting the endometrial cavity, they can even try for natural conception. If there's a good response that's about 25 to 50% reduction, you can try natural conception. If the cavity still remains distorted, then there's no other option that you have to go in for a hysteroscopic myomectomy, and if there is no response, obviously surgery would be your treatment of choice. If the patient is not desiring for pregnancy, you give long-term treatment, that's 4 courses of 3 months each. If there's a good response, you stop treatment unless recurrence occurs of symptoms, and if there's insufficient response after a certain period of time, you can consider doing a myomectomy directly for these patients. Now, what alternatives do patients have when ulipristal was no longer available, and how risky were these alternatives? See, ulipristal in the middle had been shut down for almost approximately 5 to 6 years, where we didn't have any other treatment for medical management. So if you go to see medical treatment, now these are again database from the US, not in India. The risk of death from laparoscopic hysterectomy in the US was 12 out of 1 lakh patients. That for abdominal hysterectomy was 32 out of 1 lakh patients, as compared to the risk of ulipristal acetate causing drug-induced liver injury was only 10 in 1 lakh patients. Now, if you go to see this, the CHMP, which was there, it recommended that the medicine remains available to treat premenopausal women who could not have surgery. Basically, they have seen the benefits of ulipristal acetate and they outweigh the risk of against harm. So, at the end of this, in 2021, they've given the clearance to ulipristal acetate to be used in the medical management of fibroids. Now, if you go to look at this, and this was something which I saw very well, if you look at the risk factor of drug-induced liver injury, just one question before I just move on with this talk. How many of you all just pop in diclofenac for any pains or anything without even thinking of doing your LFTs or anything like that? Just a raise of hands. We definitely do. Use augmentin or amoxicillin, clavulanic acid, UTI, prescribe it. Do we do an LFT prior to that? Atorvastatin, I don't think too many people are using, but it's used quite a lot in hypercholesterolemia. So if you go to see these 3 commonly used drugs, they have a higher risk of drug-induced liver injury, that's DILI, than your ulipristal acetate. This happened basically, if you go to see, is that it increased basically the risk. Why it happened was, there was one-off case which did appear. And it's the same thing with, even if you go to look at now meftal-spaz, which has created such a big thing. It was a known thing, but it's just been brought into the limelight. Each drug has its own risk. The point is to monitor these patients regularly. Now, if I'm using ulipristal acetate for a patient, I like to err on the side of caution. So instead of doing LFTs every 3 months, I'll do them monthly to ensure that the patient's not having any drug-induced liver injury, and make sure the patient's being monitored on a regular basis. Obviously, you counsel the patients about the pros and cons of every drug, and you explain to them. Another medical management that is there is your oral GnRH antagonist. It's probably the next step. This is probably going to be a drug which is going to be coming. It's currently not available in India, but it's set to be released sometime in the next 3 to 4 months, where there is elagolix, linzagolix and relugolix. Currently, the studies on them have shown, because it's being used in Europe and US, it's shown that it is helping in fibroids. But when I was doing my own research on endometriosis and adenomyosis, it says it shows a fantastic reduction in the adenomyoma volumes, but when the drugs are stopped, the volume does return back to its original. So there still need to be long-term studies regarding its safety and efficacy, but this drug is something that is going to change the landscape of treatment of fibroids as well as endometriosis as well. Now, what's the future treatment algorithms with oral antagonists coming into play? If the patients of heavy menstrual bleeding, if it's a type 0, type 1 or type 2, which is affecting basically in the endometrial cavity, we have to end up doing hysteroscopic myomectomies. There's no question about it. There's no role of medical management there. However, if the patients are type 2 to type 5, we can consider using GnRH antagonists with add-back therapy. If there's no response, obviously we have to go in for surgery. Again, in infertility, when we're looking at it, if it's endometrial distorting cavity, we have to do hysteroscopic myomectomy. In type 2, more than 3 centimeters, what you do is first freeze the embryos, then consider adding GnRH antagonist for 3 months. If the volume reduces, then you can go in for a transfer. If the volume doesn't reduce, then you have to end up going for surgery. If there are multiple intramural fibroids, you can follow the same thing. But you have to understand, you need to explain to the patient that, look, this does involve 3 months of treatment. We have to be a little bit practical as well when we're talking. This is all good in theory, because our patients obviously are a little bit anxious to conceive, so they may not, but patients who are motivated not to have a surgery would probably prefer a medical management rather than a surgical one. So if you go to, this is just the last couple of slides, if you look at the medical management of fibroids, we know the other medications which is there, but ulipristal acetate and GnRH antagonists, ulipristal acetate is already there and it can be used quite well. But when we look at GnRH antagonists, I think there are drugs which are coming in, the oral GnRH antagonist, and that's going to really make a difference in the overall treatment, not only just in fibroids, but in overall women's healthcare. So thank you very much for a patient hearing, and I wish all of you all a happy Women's Day today. Thank you so much.
Thank you, Rohan. Hello. Hello. Thank you, Rohan, for a wonderful presentation. Any questions?
Sorry, ma'am. Mifepristone. So, madam, there have been cases where it has been used. I personally don't have experience with it, but recently only I was telling that there was some, that was in, adenomyosis. No experience with mifepristone in medical management. As far as whatever literature I've read, it's showing ulipristal acetate as well, but mifepristone is a SPRM as well, so why not?
Because it has been worked.
Yes, absolutely.
Anybody experienced using mifepristone for a fibroid?
Only 1 to 2 cent.
Number one is, I'm a big fan of ulipristal, and it was really a problem when it was not available. I think this is something political, as Rohan pointed out. The risk of serious liver injury is 1/10 of that of drugs which are not banned, or there is no warning comes with it. We've used mifepristone when ulipristal was not available. From the day it has been available, I've stopped using it. It is pretty good with symptom control, but I'm not happy with the reduction in size. the size reduction is minimal or insignificant, whereas we get much better size reduction with ulipristal. Becomes very useful for those type 1, type 2 fibroids which are just indenting the endometrium. You give this patient 3 or 6 months of ulipristal and then the fibroid shrinks to sufficient levels so that you don't get menorrhagia and you can buy 3 to 5 years.
Hello, sir, I have one question. What liver injury does it cause, ulipristal? Either liver cell failure or liver cell carcinoma?
No. What has happened is ulipristal was used for around 3 years, quite a bit. Even in UK, people were giving ulipristal before surgery. Now, suddenly, in a period of 1 year, I do not remember the year, Rohan will be able to say, around 3 cases of acute liver injury surfaced, which required liver transplant. No, this is not malignancy. This is liver failure. And as Rohan said, in fact, the revised estimates of serious requiring a liver transplant while on ulipristal is 0.1 per 100,000. So total there have been millions of doses of ulipristal used. 9 women required liver transplant. Around 5 of them died. That is the story with ulipristal. The problem is you cannot predict it. So at the present moment, if patient has an abnormal LFT, you don't start it. But even if you keep on monitoring the LFTs, it doesn't mean that you can pick them up. There has been, even after ulipristal has come back and we've started monitoring with LFT, there's 1 case reported. But millions of doses and 9 cases of serious liver injury, it is much less than as Rohan was talking. We don't bother about when we are taking diclofenac or any other medication thinking, should I do a liver function test or a renal function test. So not malignancy.
Excuse me, sir.
One more point I wanted to add. See, basically, ulipristal became little less popular after its usage for the emergency contraception. And this trial was conducted, and in those cases, there were certain liver injuries whereby we have a safer option available. But then people started thinking the same way for the other indications as well. Probably the time will come when we start using for the other indications, we'll come to know what exactly will be the additional advantages we can avail with using various medications in the cases to save surgery.
Excuse me, sir. Is there any specific interval between 2 cycles?
Yeah, I think that has got nothing to do with the liver injury. I think if you look at the Pearl trials, it says that whenever somebody is on ulipristal, and this is true with mifepristone as well, the endometrium thickens and it is not anything atypical hyperplasia that happens. So you should allow them 2 bleeds before you restart the second course. So 2 bleeds before after the second bleed you start the next course.
Thank you so much.
Now we will move on to our next talk by Dr. Rajendra Nagarkatti, sir. And he is Clinical Secretary, Mumbai Obstetrics and Gynecological Society, and he has immediate past chairperson of the FOXI Midlife Management Committee, and as immediate past chairperson, EMOX Midlife Management Committee, and as a founder secretary, ISOPAP Mumbai chapter, and as a president, Obstetrics and Gynecological Society of Mira Biandar, past president and advisory board member, Association of Fellow Gynecologists, and as vice president, Association of Medical Consultants, and as past president and trustee in IMA Mia Biandar branch, and as a past president and trustee in Biandar Medical Association, and working as a consultant obstetrician, gynecologist and IVF specialist at Ashirwad Maternity and General Hospital, Mia Biandar, Mumbai, and at Wakad Hospital, Mira Road, and Bhimsen Joshi Municipal General Hospital at Biandar, and IVF consultant and board member at Profert IVF Center, Mumbai. Sir, please continue.
Yeah, so at the outset, I wish to thank my good friend Dr. Vivek Virkar, President of the Solapur Obstetrics Society, and Dr. Meena Gunjgotkar, who is the Honorary Secretary, and the entire team of Solapur Obstetric Gynec Society for having invited me, and especially Dr. Bhaskar Pal sir for this CME. The topic given to me today is essential micronutrients for a healthy pregnancy. Before I start, little bit on my mifepristone. I have been also using. I had used ulipristal earlier before it was banned, and as sir said, definitely there was good result. But after the ban, subsequently the ban has been lifted. But still, I have not got the confidence yet to start using it again. In fact, I was asking Prashant sir while coming here about it. So he said now there is no problem. But in the meantime, we started using mifepristone, and I have used it both in 10 milligrams and 25 milligrams. There is a good amount of symptomatic relief, but as Bhaskar sir said, there is not adequate reduction in size. And endometrial hyperplasia does happen after 6 months of usage. But generally it has been said that it's never atypical, so it's a safe thing, nothing to be worried about the endometrial hyperplasia. So moving on to the topic. Well, so nutrition is the foundation of life, is for the foundation of life throughout pregnancy and beyond, and no period of life is more important than its start. So caring for this relatively brief period of time can lead to a whole lifetime of promise. So let thy kitchen be thy apothecary, and apothecary is basically a factory where medicines are produced or drugs are produced. So let thy kitchen be thy apothecary, and let thy foods be thy medicine. So good nutrition is an important component of a healthy lifestyle and a healthy baby. And the best time to review the nutritional status to make appropriate changes is prior to conception. So the pre-conception period is very important. That is where one should begin our counseling of the expectant mother, so that her nutritional build-up is good right from the start. Everyone, all of us, should eat a healthy and balanced diet, but for pregnant women and for women who are trying to conceive, this diet takes on a whole new meaning. Dietary micronutrients intakes among the women in India. Diets in India are often of poor quality. They are generally carbohydrate rich and lacking in micronutrients. Animal sources which are rich in proteins, iron, vitamin B12, etc. Fewer than 2% of women report its daily consumption. So normally they don't eat non-vegetarian food every day, and 33% have never eaten them. And vegetarian diets are also good, but you need a good amount of good quality vegetables to bring about that kind of micronutrient necessary, and that may not always be affordable. For many pregnant women, dietary intake of fruits, vegetables, meat and dairy products is often insufficient to meet the increased maternal and fetal needs. So this is a little bit about the caloric requirement in pregnancy. We have studied this right from our MBBS days. Generally, an extra 11 to 14 kilograms is recommended, which translates into an additional 200 to 300 calories per day. And this increases the average daily caloric intake from 2,200 to approximately 2,400 to 2,700 calories per day. And that is for the expected weight gain. So the weight gain depends upon the category of the patient. If she has a pre-pregnancy BMI of 18.5, that if she is underweight, then the recommended gain in body weight is 12 to 18. If she is of the normal weight, that is a BMI of 18 to 25, the recommended gain is the normal, what we normally tell our patients, 11 to 15 kilograms. And if she is overweight, then she needs to add just 7 to 11 kg. So either ways is bad. Not enough weight gain can lead to low birth weight babies, preterm births, developmental problems, lifelong health problems, higher perinatal mortality,
baby may have mental and behavioral problems, etc. And excessive weight gain can lead to LGA babies, difficult deliveries, higher perinatal mortality. Mothers have to be screened for gestational diabetes. Even the babies may develop diabetes and cardiac problems in later life. These are some facts about nutrition. A quarter of women of reproductive age are undernourished, and an undernourished mother can give an undernourished baby. So optimal maternal nutrition, including adequate intake of essential vitamins and minerals, is important for fetal development and longer term impacts on the child's health. That is also very important. So these are the important roles of our micronutrients. One is the nutritional support. The micronutrients such as iron, folic acid and calcium play a crucial role in supporting the health and development of both the mother and the baby. Preventing their deficiencies, that is adequate intake of micronutrients can prevent deficiencies, and that can deficiencies which could lead to complications like neural tube defects, anemia, etc. So therefore, overall, micronutrients contribute to the overall well-being of the mother, ensuring a healthy pregnancy and reducing the risks of complications. This is what I was talking about in terms of the longer term health of the baby. This is about what we all know as fetal origin of adult disease. Poor diet during pregnancy can lead to adverse pregnancy outcomes and increases the child's susceptibility to cardiometabolic disease in later life. You must have heard of the Barker's theory. David Barker was an epidemiologist who in 1990 first popularized this concept of fetal origin of adult disease. It holds that events during early intrauterine development have a profound impact on one's risk of developing future adult disease. This he postulated from the babies who were born in areas of World War II, where he found that many of these problems in these areas, the incidence of the NCDs, that is the non-communicable diseases, had increased. And he correlated that to the undernourishment that these women had because of the war situations. So the Barker hypothesis is how clinicians will diagnose and prevent common adult onset diseases, and health will be defined as a function of gene and environmental homeostasis. So this is the Barker's hypothesis, and he states that low birth weight is a proxy for both fetal and adult health. It also proposes that adverse nutrition in early life, including prenatally, can increase the risk of metabolic syndrome or the NCDs, as I said, including obesity, diabetes, insulin insensitivity, hypertension, hyperlipidemia, etc. So the micronutrient deficiencies can lead to all these different things, right from intrauterine growth retardation to preeclampsia, low birth weight babies, gestational diabetes, anemia, etc. Of the sources, there are the dietary sources which are very important, and you have to encourage a good balanced diet for the patient. Wherever necessary, supplementations can be given, and of course we as healthcare providers need to give the medical guidance to these women so that the necessary nutritional demands are met. This is a chart showing the status of low birth weight babies, and you can see here Maharashtra has a big chunk, 2,82,990. Of course, lesser than some of the northern states, but still it is quite a significant number. So these are the recommendations. ACOG recommends that during pregnancy you need folic acid, iron, calcium, vitamin D, choline, omega-3 fatty acids, B vitamins and C vitamins in adequate amounts. UNICEF has also said that women's nutrition before, during and after pregnancy has now been included as a special focus area in UNICEF's India Nutrition Program. This is the WHO recommendations that daily elemental iron 30 to 60 milligrams, folic acid 400 micrograms prevents maternal anemia. Again, folic acid as a routine antenatal supplement prevents neural tube defects. Calcium is necessary to prevent preeclampsia as well as for bone and bone development. In certain pregnancies, vitamin A is also recommended. And MMS, that is micronutrient supplementation, multiple micronutrient supplementation were associated with an average 11% reduction in low birth weight babies. This is also the Lancet review, which you can see that all these different the complications like preterm births, very preterm births, small for gestational age babies, neonatal deaths, etc. were all reduced with iron and folic acid supplementation, but not as much as when you give a multiple micronutrient supplementation. The last row is where you find the maximum decrease in low birth babies and all the complications. So which nutrients are essential during pregnancy? We all know folic acid, folate requirements increase in pregnancy in order to meet the maternal and fetal needs and for the greater DNA synthesis and rapid cell division that happens during fetal development. An inadequate periconceptional maternal folate status has been associated with neural tube defects such as spina bifida, anencephaly, and thereby highlighting the importance of entering pregnancy with adequate folate stores. Generally, in patients with recurrent pregnancy loss, we recommend at least 1 to 2 months of folic acid supplementation before they even begin the next pregnancy. In rural regions of North India, the prevalence of NTDs is almost 54 cases and 24 cases and 51 cases per 1,000 for anencephaly and spina bifida. And this has led to an increase of 300 babies being born with NTDs every single day, resulting in over 3 million babies of NTDs over the past 3 decades. So that is the load of NTDs that we are having in India. This is something which is very important, which we can guide our patients for as a dietary source of folic acid. Leafy vegetables like spinach, asparagus, lettuce, legumes like dried or French beans, peas, lentils, etc., egg yolks, baker's yeast, fortified grain products like cereals, breads, pasta, breakfast cereals, sunflower seeds, liver and liver products, etc. You also get folic acid in moderate amounts in fruit juices like orange juices, pineapple juice, melon, grapefruit juice, etc., and in vegetables. The next important is vitamin B12. Again, it basically helps in the homocysteine pathway. It brings down the hyperhomocystinemia by functioning as a coenzyme for reactions in the developing embryos and thus plays a role to reduce homocysteine levels to ensure a favorable pregnancy outcome. Vitamin D, again another very important nutrient. Deficiencies can correlate with preeclampsia and preterm births, and supplementation of vitamin D is very, very safe. Generally, one tends to do vitamin D levels, but vitamin D levels can be little expensive. It's almost 1500 rupees, and the vitamin D toxicity levels are quite high. The normal levels are 20 to 30 or up to 30 nanograms, but the toxic levels are more than 100 nanograms per ml. So there is a big gap between your normal level of 30 and a toxic level of 100. So I feel that you can definitely give vitamin D supplementations up to 2 weeks, up to 2 months without doing a vitamin D estimation. Also, dietary sources or the natural sources are important. I'll come to that. These are the natural sources, that is sunlight exposure, fish like salmon, tuna, etc., milk, cereals, pork, mushrooms, ricotta cheese and cod liver oil. These are some of the natural sources of vitamin D. And why is it important? It helps the body to use calcium. It helps in the calcium absorption. It maintains blood calcium and phosphorus levels, and it has an anti-proliferative action. And recent studies have also indicated an increased risk of autism in infants with vitamin D deficiency. What is important, I always advise, is to do a serum calcium level, if at all, before you start vitamin D, because if serum calcium is on the higher side, then definitely yes, we don't need to give vitamin D, because that will increase the calcium absorption and lead to hypercalcemia. But if the calcium is normal, you might as well go ahead and start vitamin D. Iron is another important nutrient. Why is it important in pregnancy? It causes a surge in the volume of blood in the body. The expanded volume can go up to 50%, and thereby we all know about the hemodilution that occurs, and thereby the decrease in the iron levels, hemoglobin levels, and therefore iron supplementation is necessary. Anemia in pregnancy can lead to all these different effects: poor weight gain, preterm labor, preeclampsia, intranatal effects like dysfunctional labor, hemorrhage and shock, Postnatal effects like puerperal sepsis, the entire healing process after delivery becomes slowed down with anemia. There is subinvolution, there can be fetal effects like risk of prematurity, IUGR, low birth weight babies, poor Apgar score, depleted iron stores in the neonates, and anemia in the infancy period. The prevalence of iron deficiency anemia in pregnant women is amongst the highest in the world, and it is associated with all these different problems. So there is reduced cognitive performance, increased risk of pregnancy-induced hypertension, perinatal mortality, behavioral defects, and So now iron supplementation doses, what they have studied is that even small doses of iron supplementation can bring about a correction of the anemia. There is this study in the EJCN which said that should we lower the dose of iron when treating anemia. So they found that even with low dose iron supplementation, 30 to 50 milligrams can also bring about a correction of anemia without the side effects that we see with a normal 100 milligrams of iron. This is the next supplement, that is iodine. WHO guidelines suggest an intake of 200 to 300 micrograms of iodine daily for pregnant women. Iodine, we all know, plays an important role in normal brain development in the fetal and postnatal life. Zinc supplementation, again, it limits, the zinc deficiency limits neurodevelopmental functions in the fetus. So therefore, zinc supplementation in pregnancy, zinc supplementation is useful in pregnancy complications including hypertensive disorders, low birth weight, spontaneous preterm births, and gestational diabetes mellitus. These are some of the other supplementations which are necessary: omega fatty acids, essential amino acids, and calories. Now, these are some of the foods which are rich in omega-3 fatty acids: flax seeds, walnuts, sardines, salmon, soybean, halibut, and some of the other seafoods. So these are the different micronutrients. At every level, they have their important role to play. Again, this slide shows us the different uses of the micronutrients, right from calcium, iodine, choline, vitamin A, vitamin C, D, B6, B12. It helps in different kinds of development, including the neurodevelopment, important for development of fetus's brain, skin, eyesight, everything. So all of these micronutrients have an important role to play, and that is where the role of multiple micronutrient supplementation comes in. MMS was associated with greater benefits in undernourished and anemic pregnant women. It led to a reduction in babies considered as low birth weight babies and SGA, and reduced the incidence of preterm births. This is the importance of preconceptional micronutrient therapy. Supplementation with MMN may be a good strategy to adopt in healthy women trying to conceive, and as also those who are having fertility problems. Now, should pregnant women go on a low carb diet? Yes, carbohydrates in excess is not good, but women should not go on a low carb diet, let alone carb free diet. In fact, it is recommended that at least half of the calories that a woman consumes should be carbohydrates. The main reason for this is because carbs are known to turn into glucose, which is necessary for the unborn baby, and they are known to provide the baby with nutrition, proteins, and healthy fat. So all of these are quite essential to the proper development of the baby. What type of carbs should the pregnant woman avoid? There are many carbs which are what we call the bad carbs, which a pregnant woman should avoid. Some of these types of carbs includes your donuts, candy, fast foods, etc. These carbs are known to cause weight gain, but without a positive effect. It can also sometimes lead to gestational diabetes. So although eating bad carbs will not necessarily harm the baby, but they will not give any health benefit. This is another thing which needs to be controlled. Too much of caffeine is not good during pregnancy. Coffee, tea, and some I don't know, pop, but this coffee, tea has a good amount of caffeine. So the coffee, this should be limited to 3 small cups of coffee per day is safe. Switch to decaf or tried half decaf, but all these things cannot be understood at the rural level, but yes, in the cities we can try all these things. So this is the Eat Well plate. It should have a balanced combination of fruits and vegetables, of carbohydrates like bread, rice, potatoes, etc. There should be an adequate amount of protein input, that is meat, fish, eggs, beans. Foods and drinks high in fat or sugar also is also necessary. Of course, milk and dairy products. These are some of the future trends and innovation. What is coming up is personalized nutrition based on individual needs and preferences. Precision medicine, that is integration of genetic testing, metabolic profiling and predictive analytics in maternal fetal care, can revolutionize the delivery of personalized interventions. And today is the era of digital health solution. Mobile apps, telemedicine platforms and virtual consultations provide convenient access to nutritional guidance, which should be made available to the pregnant women. So every woman deserves a healthy pregnancy, safe delivery and a healthy infant, and therefore introducing Pregna Care, which is a product of Meyer, which is very, very popular amongst our patients and should be recommended for all our patients. It gives all the different essential micronutrients, right from magnesium, vitamin C, iron, nicotinamide, zinc, B6, B1, B2, folic acid. So generally just one tablet daily is required. It gives the complete nutrition care. Even it has received the Queen's Award, an innovation award is made to Vita Biotics Limited for developing Pregna Care range of tablet. And it is the only product with excellent clinical trials also. There have been different clinical trials. This was by Kiran Koilo and Dr. Ramdas. The second one was by Dr. Amit Patki and Maulik Joshi. And the third one was in London by Louis Bro. So all of them have corroborated the use of prenatal Pregna Care as a good source of maternal supplementation. So in takeaway or in summary, micronutrients are essential for supporting maternal and fetal health during pregnancy. A personalized approach, tailored recommendations, monitoring and interventions based on individual needs is what we need to advise, and continued research is necessary. Ongoing studies, advancements in technology and collaborative efforts among key stakeholders are driving innovation in prenatal nutrition with a focus on improving access, efficiency and equity in micronutrient support for pregnant women worldwide. Thank you.
Thank you so much for your elaborative and informative talk.
Thank you.
Any questions from the audience?
Our next speaker is Dr. Bhaskar Pal, a senior consultant gynecologist at Apollo Multispeciality Hospital, Kolkata. He is a chairperson, endoscopy committee, SAFOG, chairperson of AICC RCOG 21-23, immediate past president, IAGE, Foxy representative to SAFOG 21-23, chairperson, Organizing Committee AICOG 23 Kolkata. He is a past president Bengal OBGY Society, vice president Foxy 2017. He is a clinical examiner for MRCOG Part 3 and author of over 40 papers and book chapters. After this introduction, I feel that he must be a hardcore teacher. And we are eager to hear you, sir.
I'll come to that in a moment, madam. Thank you, Madhuri, madam, for the kind introduction. I wish all of you a happy Mahashivratri, and thank you very much for coming here. Many of you are fasting, but Monica very thoughtfully has arranged our Mahashivratri special dinner of tonight, so that those who are fasting can eat that. But I'm grateful to all of you for having me. Dr. Virkar, Dr. Meena, Dr. Praveen, great to see friends like Girish and Milind, and also seniors like Dr. Doshi. I bring you greetings from Kolkata. Those of you who've been to Kolkata have familiar with some of these sites. What madam you told is, I actually graduated from Calcutta and then by the All India entrance came to Sion Hospital. to do my MD, and then I was a lecturer, senior lecturer at Meyer Hospital I was not so unpopular as a teacher, and to the extent that my HOD, Dr. Rawal, did not accept my resignation when I went off to UK, saying that you need to come back to this job. And unfortunately ended up in Calcutta. But there is a reason why I'm here today, apart from other things. I was in Solapur in August when Akluj Society held the Barkha conference. That was my first visit to Solapur. But I have led several organizations like IAG, the RCOG in India, apart from Bengal Society. But I have been in Foxy in leadership positions since 2005. I have served the journal as the honorary biostatistician. I have been chairperson of a committee. I have been vice president. I have been governing council member of Indian College of Obs and Gynae. I have been representative to an international organization which I just finished, and like to seek your blessings and support for the post of Foxy President, the elections to which will happen in August this year. Now, this is a very favorite topic of mine in the sense that this is a lecture which is curated from years of experience, personal and friends, and where we've got stuck and where we've learned something and learned something new. And this is a quote from Ian Donald from the book most of us are familiar with, the Practical Obstetric Problems, where he writes that most of us, we forget our successes. It is our failures which stand out like keloid scars, that even now, possibly if you have a bad case of eclampsia, when you lie down in bed at night and close your eyes, you will think of some eclampsia patient you lost many, many years back. But what happens is that he goes on to stress that we all make mistakes. It is common to make mistakes, and he writes that if there are some mistakes he couldn't make because he just didn't have enough time to make them. Now, there are various problems at cesarean section. Anesthetic problems I'm not going to talk about. Problems with delivery of the baby I'm going to talk about. Surgical problems I'm going to talk of some of them like bleeding and injuries. I'll start with the thick vascular lower segment. In thick vascular lower segment, the first thing that we need to check that it is not a dextrorotated uterus, and what we are seeing is the lateral part of the uterus. Once we've checked that, we've seen many of our seniors ligating the veins, taking time to ligate all the veins before they make an incision. These days, I hardly see anybody ligating veins. Maybe we've got better lights, better suction, better assistance. What we tend to do is to press with the doyens on the lower segment so that the veins don't fill up from below. What is important is to be quick, not to be distracted by the blood. In initial days, people get scared to make an incision when there is blood, and they start poking with their fingers, which doesn't help. So what people need to do is to, after every stroke of incision, use the index finger of the non-dominant hand to check whether you can feel the membranes. And once you feel the membranes, you know you are there. Now, a very good suction and a very good assistant is important, but more importantly, when you have a thick lower segment, the uterine incision needs to be bigger than usual because the uterine wall is not that compliant. The second one I want to talk about is placenta previa. Now, in placenta previa, preoperative preparation is as important as what we do in theatre. So, we need to keep adequate blood and component ready. We need to have an experienced obstetrician. And even now, if I do a placenta previa cesarean, I at least ask a colleague to hang around in the operating theatre complex, because if you get into trouble, it's very useful to have a second person who's as experienced as you are. Should you give a spinal or GA? These days you can give spinal, but I keep saying that we'd rather choose the anesthetist and leave it to the anesthetist what they want to do. We need an experienced neonatologist, especially if it is an anterior placenta previa, because the baby might come out exsanguinated. Should you consent for hysterectomy? No, you should not, unless it is a placenta accreta. You should put hysterectomy in the list of complications, but not consent for it. Irrespective of whoever is the anesthetist, I would always insist in this situation, and also in any patient who is likely to have PPH, to have 2 wide bore IV cannulas before we start, and not when the patient starts bleeding, because the bleeding will happen with such ferocity that we won't get an IV access. It's a good idea to check the presentation and position of the placenta the day before or the morning of the surgery, just to recheck once. I'm not going to get into placenta accreta today, that's a separate topic. Now, when we make an incision, and if it's an anterior placenta previa, if it's a posterior placenta previa, delivering the baby is not a problem. It's an anterior placenta previa, we anticipate bleeding during the uterine incision. What we try to do is to separate the placenta and expose the membranes. Usually, unless it is a minor degree placenta previa, we need to go up above the placenta, and if we can find the membranes, rupture the membranes, grab a leg and take it out. If you can't, then you have to cut through the placenta. Easier said than done, because the placental cutting requires experience, because it doesn't give you the giveaway feeling that you get when you are doing the cutting the myometrium. And the baby might come out exsanguinated. You deliver the baby and clamp the cord immediately and hand over to the pediatrician. The next issue that comes in placenta previa is bleeding placental bed. Now, when I was training in SIAN, one of our professors was a self-proclaimed placenta previa specialist. He or she would insist that any placenta previa during cesarean during the daytime, you call him or her. And what he or she would do is to come as soon as the placenta is delivered, start suturing, and the suturing would never end. We realized much later it's a completely wrong thing to do. What you do is, you do your 3 P's: pack, press and pray. You pack with a hot pack, press it for 5 minutes by the clock. What do you do in the meantime? You can do a lot of things. You can massage and compress the uterus. You can use oxytocin. These days we do not use methadone, but this is one situation where I always use methadone, because that's the only oxytocin which theoretically works on the lower segment as well. I would also tie the angles of the incision at that time, because later on that bleeding will not go and contaminate the field. Somebody said once in a lecture that I don't believe in God, should I pray? Yes, you should pray. I'll tell you a small story. Famous physicist Niels Bohr, a journalist went to interview him, and he had a horseshoe above his house. Now, horseshoe is supposed to bring him good luck, and the journalist said, Dr. Bohr, you are such a renowned scientist, you believe in superstitions. You putting a horseshoe there. He said, I've been told it brings you good luck even if you don't believe in it. So even if you don't believe in prayers, please pray. That's great, because you can spend your 5 minutes. At the end of 5 minutes, remove your packs, whatever bleeding sinuses are there, secure them using either a figure of 8 suture or a horizontal mattress suture. That doesn't help. We need to escalate. I will come to that later. The third situation I want to talk about is previous cesarean. And in previous cesarean, there are 3 kinds of problems that we can come across. Number 1, parietal wall adhesions, the uterus completely stuck to the anterior abdominal wall. Number 2 is that the omental adhesions to the anterior peritoneum, you cannot safely open the peritoneal cavity. And the third thing is the high adherent bladder. As I said, adherent placenta, I am not getting into that. Now, when I was the committee chairperson, we did live cesarean workshops in 30 venues across the country, and we found that while most units put in a Foley's catheter, a very small percentage of units, around 10%, did not catheterize the patient. They'll tell the patient to pass urine and come and lie down on the table. But this is one situation you must have an indwelling catheter. And then the key is a sharp dissection. What do we do about opening the peritoneum? If there is, we think that there are bowel adhesions to the anterior peritoneum, we try and go as high as possible, and then try and go lateral if needed. Only when we can feel the peritoneum thinned out, that is where we open the peritoneum. As far as the bladder dissection is concerned, always go for the sharp dissection. Usually you should be able to get it from the center, because if there are bladder adhesions and the uterus is stretched, like in pregnancy and fibroid, the bladder dissection is much easier than when the uterus is normal sized. If you cannot, then you approach it laterally. What happens if the uterus is stuck to the anterior abdominal wall? Usually you will find a window from where you can start separating it from the anterior abdominal wall and deliver the baby, and later on deal with the uterine bleeding. If at all theoretically you cannot find that window, then you need to reflect the bladder up and go below the bladder, which technically becomes an extraperitoneal caesarean section. The next thing I want to talk about is floating head delivery of the baby. Now, the first thing to do in floating head again is correct the dextrorotation and ask the assistant to stabilize the lie. The problem happens is when we make the uterine incision, suddenly the liquor goes out in a gush and the baby turns. Very much like why women in pregnancy have a torsion soon after delivery or at 14 weeks. There's a lot of space and the fluid has just run out. So what we need to do is to control drainage of liquor. What is controlled drainage of liquor? we make an incision of the uterus which can just allow 2 fingers in comfortably. And with that, we regulate the amount of liquor that comes out a little bit at a time. And gradually, as the liquor drains out, we can feel the head coming to rest on our fingertips. And that is when we extend the incision and deliver the baby. If the head slips, do not panic, grab a leg and deliver at bridge. Bridge delivery is coming back into vogue, but otherwise I used to tell my juniors that this is the only time you will get a chance to do a bridge delivery. If you are in problem, then you can apply a forceps or a ventouse. I personally use a forceps. I will not go into the details of the forceps delivery. This is not a lecture on cesarean section techniques, but I just kept part of this video to show that these days you do not need to develop a bladder flap. You can straight away incise on the peritoneum and get into the uterus. And the second bit is that this is a cephalic application. So put your hand in. I've got it here, madam. I'm sorry, I've got a bad throat. It's too much of speaking, I guess. So essentially, cephalic application, you examine which way the baby is and then put your posterior blade as the assistant to hold it and then put the anterior blade. If you put it wrong, you have only yourselves to blame, cannot tell people that you did not check it well. You can use a ventouse as well. I would not get into that. I think the biggest challenge is cesarean section in second stage. And it is challenged because of 2 reasons. Number 1, delivery of the baby is a problem because these are usually big babies, there is no liquor and a deeply engaged head. Second problem is that there is a high chance of extension of uterine incision, which could be lateral extension, inferior extension, inferolateral extension. Many a times, inadvertently, we might take an incision on the vagina and then the extensions are more common and more dangerous. All these would lead to hemorrhage, initially traumatic and atonic, and then it will become coagulopathy as well. It can increase the risk of ureteric injury and increase morbidity. So essentially here as well, we also need a skilled obstetrician and neonatologist. We need to check when was the last hemoglobin done and decide whether we need to arrange for blood or blood products. And we try to ascertain the position of the fetal head. I say try because I have been a lecturer, Raju has been a lecturer, and sometimes registrar will call us and say, I cannot make out what is the position of the baby. And I do not know what, I guess Raju also did the same thing. He was my senior. We went and we'll examine and we had no clue, but we'll say, I think it is this. Because you are not taught to say that I don't know. If your junior can't make it, you have to at least make a comment on that. It is much later when I went to UK, I realized even consultants would come and write on the paper, I can't make out which way the head is. But what is important is this, these days there are units in India which are trying an ultrasound in labor ward to see which way the baby lies. But the point is try to ascertain the baby's, which way the baby's head is, but many a time you cannot. This is another situation where we need to have a Foley's catheter. If it is not a cesarean for fetal distress, we need to explain to the mother the risks to her and to the baby. Now this is a very important point. Where should I take the uterine incision? My lecturer at SIAN had taught me that whenever you are doing a full dilatation section, take your incision 2 finger breadth above where you would normally take. And lecturers are from whom we learn all our work, isn't it, in PG. And I followed that all my life. Till one day in 98 in UK, I did a section, full dilatation. Full dilatation sections are much worse in UK and much more common because they push women into normal deliveries till kingdom comes. And they will all end up with horrible complications. And this lady had a bad extension and we realized we've gone into the vagina in spite of going 2 finger breadths above. And then we realized that this is not a good way of teaching. This is number 1, everybody's finger breadths are different. Number 2, if you close your eyes and think in the last 10 cesarean section, where did I take the incision? Did we take it at a uniform place? Did we measure it and take? No, we take it in a window which is approximately 1 centimeter here and there. And that makes a lot of difference. So we needed an objective way to teach people where they should take the incision. And that objective way is identify the loose UV peritoneum. And then identify the upper edge of the UV loose peritoneum. Now this is one case, and previous cesarean is another case where we will cut the peritoneum separately, as opposed to what I showed in the video. So identify the upper edge of the loose UV peritoneum and make your incision just below that. That gives you the best chance of not getting into the vagina. The second thing is curve the end of the incision upwards like a U or a smiley. Why? Because if it extends, it will extend into the uterines. My teacher in SIAN used to say that We are gynecologists. We need to know if the uterus gets injured or the uterine gets injured. If you injure something else, you have to call somebody else. So basically, if you make a U-shaped incision and it extends, it is in your territory. Now, what do we do is we actually have to push the head up. I'll come to that in a moment, and the rest of the things I've already said. But what is important is do not use single blade of the forceps as a vectis. There are things which get written down in textbooks, handed down generations without anybody verifying it. Please think of it, that when you are putting your hand in there, you are feeling where you're going. If you put a single blade of forceps, you have no clue where it is going. And the current obstetric manual in UK says that it is not only illogical, it is potentially dangerous. You can actually dislodge the head, bring it at the level of the incision, and then put the forceps, both blades normally, but not single blade. I'll talk about extensions before I get into the delivery of the baby. The extensions are essentially lateral or inferolateral. Now, what do we do here? Number one is call for help. If you think you are not qualified to manage it, call for help, but don't let the patient bleed to death. Till that time, you'll have to control the bleeding. Now, I know a lot of people exteriorize, but there is no evidence to suggest whether exteriorization is better than keeping it inside. But even if you are not in the habit of exteriorizing, please exteriorize the uterus in this situation because of two reasons. Number one, upward traction reduces the blood loss and improves your visibility. Number two, the ureters fall back. Then you ensure that the bladder is sufficiently down, and then you start suturing. Now, please do not suture and the patient is bleeding to death and you are not suturing, waiting for your senior to arrive because you might take the ureters. Please remember, the ureter is only useful to the woman if she is alive. So, you have to make sure that the bleeding is controlled. If you can control the bleeding by pressing till your boss arrives, it's fine. Now, what is important is place the sutures under vision. What if you can't see the apex? What do? You go back to your first post-residency and what we were taught to do for episiotomy extensions. Many a times we can't see, suture where you can see, keep the thread long, pull it down as a stay suture, gradually go up, and it has never happened, we've never found the apex. Similarly, here also the same story. Suture where you can, and where you can see, and then keep the thread long, pull it up as a stay suture, gradually go down, suture the apex only when you can see the apex. The only thing is that if you decide to put a drain, it is not mandatory, never put a suction drain because it gets blocked very, very easily with the momentum. This is a situation where you need to put a tube drain. How do you deliver the baby? Make sure that the bladder is empty. We've already spoken about the incision. The incision needs to be big because this is a big baby. What has happened is that it is a vacuum created between the baby's head and the pelvis. And we need to break that vacuum gently. Do not fight the fetus, which means do not manipulate during a contraction. Break the vacuum gently. Some people, if you can put your hand in anteriorly, that's great. If you can't, you can put it laterally and gradually sweep it anteriorly. Some people find it useful to use their non-dominant hand. But what is important is that once you break the vacuum, what happens is that you can hear the passage of sound going like a slush or slurp, and then you know that you can dislodge the head up. We do not use tocolytics because it is not that readily available. Is it a good idea to push from below? It is, but we need to be careful. In UK, the maximum number of litigations at the present moment in obstetrics is impacted fetal head, somebody is pushed from below and the baby's got depressed fractures. And that is why I always suggest that the surgeon who's going to operate, I would assume is the most experienced one there, should do a vaginal examination just before scrubbing, push the head up as much as possible, then assign a junior to push the head up who should put their fingers in the vagina before we start scrubbing. And we tell them, do not push with your fingertip, push it with the flat of your fingers. But it is important that we can dislodge as much as possible and then we do that. As far as we are concerned, we were fortunate that we were trained in the Patavardhan's method, and so if we cannot dislodge the head, we always resort to Patavardhan's method. Now, we were always taught there are two Patavardhan's method, Patavardhan's method and modified Patavardhan's method. Patavardhan method you do for back posterior and modified Patavardhan's method you do back anterior. And at those days you could not cross check because the Indian journal was not on World Wide Web as it now is. Many years after teaching people Patavardhan and modified Patavardhan. I think all of you know Dr. Parag Beniwale from Pune. One day he taught me what you are teaching is wrong. Because you know that his wife is the grandniece of Dr. Patavardhan. And then he showed Dr. Patavardhan's original writing where he describes two maneuvers. One is a Patavardhan's maneuver for back anterior and one Patavardhan maneuver for back posterior. You can now go and search for that in the Indian journal, you will get it on the net. So the Patavardhan's method is based on the fact that we have already said that the head is very low down, and we've already said you take the incision higher than normal. So if you take the incision at the right place, and if it is really a deeply engaged head, whenever you take the incision, what would present is the shoulders. And if you try to take any limb out, what will come out is one arm. So you have to, based on that, you proceed further. Now what happens if the back is posterior, which is the more common presentation? You deliver the arm that comes out, then you go and find that side leg, take that out, then you find the other side leg, then you deliver the trunk, then the hand, and then the head last. Now this is a video shot in the emergency of Sion Hospital, so quality is not great, and you can see that one arm is out, the same side leg has come out. Now you're going and trying to find the other leg, and then you just deliver the trunk and finally deliver the head. Now I can take a little bit of credit of popularizing Patavardhan method to the people who matter in UK, and now it features in the obstetric manual, and they also describe it the correct way. They describe Patavardhan technique for spine lateral or posterior and Patavardhan technique for spine anterior. And this is what you do when it is back anterior. Keep the back anterior, deliver one upper limb, and followed by the other upper limb. Then you deliver the fetal back, and then the abdomen, and then the lower limbs. And you deliver the head last. Now a lot of people would say that in Western papers, they talk about reverse breech extraction. What is reverse breech extraction is very similar to this, but you get the hand out, you put the hand in and then go for the leg. Those who have done that and the hand has come out know how immensely difficult and impossible to put the hand back in a uterus where there is absolutely no liquor. So this is again a video shot again in the Sion emergency. The only criticism is I think they could have done it with a slightly bigger skin incision. You will see that later. So going for the first arm. So once that, this is a really big baby. Once the first arm comes out, somebody needs to give a gentle tug on the arm onto the other side so that you can easily reach the other arm. Then you do what is like a reverse breech, which means you hold the baby like this. As a little bit baby comes out and you go forward. Be careful that you do not injure the liver or the spleen, etc. And there is some people have developed a modification of putting traction on the scapula to get that. This struggle is because the skin incision is a little insufficient. For those who are trained, it is actually very easy to do, looks very complicated. So this is again from the Moe manual, and the last thing I want to talk about is managing hemorrhage at cesarean section. Now different units have different protocols. Some units say that you should do compression sutures first, then you should do a devascularization, and then you should do a hysterectomy. Some units say you should do a devascularization first, then you should put compression sutures, and then you should put hysterectomy. Over the years we've realized that this is a theoretical debate. We usually put compression sutures and devascularize, and we do them both. But we do not do an internal iliac ligation for atonic PPH. It is a pretty useless surgery for atonic PPH because it decreases the pulse pressure at the level of uterines only by around 50%. It is a very useful operation to do when you have got a traumatic PPH or a broad ligament hematoma, but not in an atonic PPH. So what we do and what we insist as part of devascularization, very easy to teach juniors, is we teach them to do a mass uterine artery ligation and to do a utero-ovarian artery anastomosis ligation. All of us learnt uterine artery ligation very early in our lives. But it was Dr. Daftari from Wadia who actually taught us that doing that is not enough. You would have to do the utero-ovarian anastomosis also. When we were training, we'll do this and then move on to internal ilia. Completely waste of time. Now again, there are people who will show you videos that you dissect the uterine artery to see that before you ligate it. Absolutely not. When you are trying to teach something which is life-saving and which juniors can replicate very, very easily, you need to teach them the simplest possible procedure. And what you do is you take a bite at the level of the bladder reflection, which is 2 centimeters medial to the lateral end of uterus. Take it from front to back, and then from medial to the round ligament, choose an avascular area from where you bring the stitch back, and you do that on both sides. So basically take the entire bulk which will contain the uterine artery. So take the needle out from the back, stretch the round ligament and come from medial to the round ligament in an avascular area, and you tie the uterines and tie it on both sides. Very easy to do. You see one, you can do the second one. And you have to repeat it on the other side. Uterovarian artery anastomosis ligation, even simpler. Stretch the tube from just below the tube in the avascular area, go from front to back, take the entire leash of vessels and come from back to front from below that in an avascular area, and do it on both sides as well. Now when we do compression sutures, the first thing that you need to do is to make sure whether your compression suture is going to work on that. And how do you ensure that? You ensure that by compressing the uterus bimanually and asking somebody to look vaginally. If there is a significant decrease in the bleeding, then you know that yes, compression sutures are going to work. And you have 2 options. One is Billin sutures, of which I am not a fan of, or you got the Heman sutures. The reason Billin suture I am not a fan of is, number one, anything in emergency is not great if it is complicated. I don't think that a postgraduate trainee can see one Billin suture or do one Billin suture and then go ahead and do one more if the picture is not put up on the emergency OT. Number one. Number two, it requires an open uterus. Most of the times when we decide to put a compression suture is after we've closed the uterus, which means I have to open the uterus again to take this suture. So what you do is essentially start from the front at the lower segment, go outside in, and then just come out inside out. Drape the entire suture like a sari pallu to the back of the uterus, and posteriorly again at the level of incision come inside, go back out posteriorly, again drape the stitch again, and then bring it, and then go from above the incision outside in and come out inside out below the incision, and then you tie it and it will look something like this. So this is the main reason why we do not use it. So why do we use it? Why don't we use it? Because we've got a better option available. And this is Heman suture, which is devised by Professor Arul Kumaran. It is easier to teach. It does not require opening of the uterus. Just above the bladder reflection, you take a stitch 2 centimeter medial to the lateral border of the uterus. Take one on each side and tie it on the top of the uterus. 2 centimeter medial to the lateral of the border of the uterus. Does it ring a bell? Same place where we said you take the suture for the uterine artery ligation. And that is why Dr. Mahesh Gupta from Ahmedabad has devised a suture which is called the Comox suture. Compression and occlusion. So what he does is that his suture has got 2 needles. So you take one bite, 2 centimeter medial to the lateral border of the uterus, go from front to back, and then the one suture you cut off and tie it on the top, and the other suture you use the needle to come back again from back to front, medial to the round ligament, and tie it for the uterine. So one bite you can achieve both. So this is how it will look in the end. And this is again a video from Sion Hospital on compression sutures. The only mistake, you can see the uterus is closed and you do not need to open it. The only difference is that I would prefer that you do it with a straight long needle and use number 1 Vicryl, although these are all described with number 2 chromic catgut. But number 2 chromic catgut is not available at the present moment, and chromic catgut gradually being phased out. So take the bites both before you suture it. And then when you suture it, it is very important that you gradually tighten the suture and do not tighten it at one go. Because otherwise, by the time you finish your surgery, that it will become loose. So you gradually tighten it over a period of 15 to 30 seconds, and your assistant holds that knot, and then you put your second throw there. I'll just show the end results. So in the end result will look like this. It needs to be going into the uterus. It should be denting the uterus. I will not talk of hysterectomy in detail, but I will talk 2 or 3 things about hysterectomy. When we were postgraduates, hysterectomy mortality used to be very, very high. Number one, patients would come in late. We didn't have as much of blood products. We didn't have so good taluka hospitals which will do a good job before sending the patient. So by the time patients came in, that they were already in DIC. Many of them, even a hysterectomy would not save lives. And many a time people would delay doing the hysterectomy because of a cultural belief that you do not take out the woman's uterus. The uterus goes, she can't find another uterus. There was no uterine transplant there. Wife goes, husband can find another wife, isn't it? So, but now we know that the woman's life is more important, so we do hysterectomy much sooner. So I don't think hysterectomy has any longer a mortality rate or a morbidity rate that used to quote earlier. It is a very safe surgery, but we need to do it sooner rather than later. I think we do our compression sutures, devascularization, give it 2 to 3 minutes, see it's not working, just go ahead with a hysterectomy. The 3 things I want to tell about a hysterectomy is, number one, it has to be a skilled surgeon. Should you do a total or a subtotal, you should always aim to do a total. But especially if it is fully dilated, whether you manage to do a total or not, you will know only 6 weeks later, whether you've left a small cervical stump or not. If it is a partially dilated uterus and the cervix and the uterus is open, you can make sure that it is total, because you can actually hook up the cervix and put your angle clamp. The second thing is that my teacher, Dr. Geeta Niyogi from Sion, taught me that during a hysterectomy, she taught me to ligate the vascular pedicles twice and said that keep on doing this till you become a professor. Because I never became a professor, I always ligate the vascular pedicles twice. But what I teach people is put an extra ligature to all your stump compared to what you will do in gynecology. We get called for patients who've had an obstetric hysterectomy and then bleeding inside and the patient had to open. Almost always it is an uterine stump which has become loose, or very rarely it is a rectus sheath hematoma. So basically that is why you always need to put an extra stump to everything because of the edema. As the edema subsides over the next 6 to 8 hours, the patient starts bleeding. The third thing is, what do we do in gynae? Clamp, cut, ligate. In obstetrics, we do clamp, cut, drop. We do clamp, cut, drop and finish the hysterectomy, only then we start ligating. It takes less time and patient loses less blood. As I said that for atony, we are not fond of internal iliac ligation, but only thing to remember is the life-threatening problem in doing an internal iliac ligation is injury to the external iliac vein, which lies lateral to the internal iliac artery. So whenever you're putting your mixture, make sure you're going lateral to medial, that way you will not injure the external iliac vein. And finally, assess the blood loss accurately, assess the need for thromboprophylaxis, observe the patient, document and give an explanation to the patient. And I will finish again with a quote from Ian Donald, who dedicates practical obstetric problem to those. It just acknowledges the fact that medicine is an inexact science and we all make mistakes, and our humility should increase with our knowledge and skill as it advances. If it makes us more arrogant, there is something wrong in us. And I wish all of you a happy International Women's Day. The women and men, I think we are the small group of men who survive on women. Without women, we will be nowhere professionally. And thank you very much. I seek your support and blessings again. I'm happy to answer any questions.
Thank you, sir, for a wonderful lecture. You have made very difficult things very easy, and you have given many practical tips also, and we are really convinced that you are a great teacher. Thank you, sir.
Sir, please wait there. I request chairpersons to felicitate Bhaskar Pal, sir. Request President to join. Dr. Rajendra Nagarkatti sir to come up on stage for fellowship. Dr. Rohan sir. I request President to felicitate our chairpersons. As we are late already, we will move upon to our panel discussion on complications of hysterectomy. To moderate the panel, I request Dr. Milind Shah sir. Sir actually needs no introduction to our society, but for a formality, sir performed many posts like past president ISOPAB, past president, vice president Foxy, past second vice president ISPAT, and founder president IHRF. And he travels to many cities and countries to deliver many orations and lectures, many books in his credit. So I request Milind Shah sir to moderate the panel. Now I request the panelists, Dr. Bhaskar Pal sir, Dr. Rajendra sir and Dr. Rohan Palshetkar sir. They have been already introduced. I request them to occupy for the panel discussion. Then our next panelists are Dr. Sulbha Zamre madam. Madam is a senior dynamic OBGYN practicing since 35 years in Solapur, Zamre Nursing Home. Worked as honorary consultant at Railway Hospital, lecturer in VMGMC Solapur, past president of SOGS, and worked as various capacities in arranging many conferences. Dr. Chandrakant Jadhav. He is Assistant Professor OBGY BJMC Pune, Director at Sanjeevani Nursing Home, Consultant at Yashodhara Super Speciality Hospital. And Dr. Monica, she also needs no introduction. She is a young, dynamic, multitasking member of our SOGS, Consultant OBGYN at Mangala Nursing Home and Atharva Fertility Center. She became Zonal Coordinator just now, and she performed many posts like Web Coordinator, Youth Coordinator and all. I request Shah sir to start the panel. Thank you.
Thank you very much, Meena. At the onset, let me wish you all a very, very happy International Women's Day. There is so much of majority of females here, as normally it happens in any OBGYN society. But friends, looking at the faces of all of you and all the panelists as well as the previous chairperson, I realize now it's a tough task for me because everyone is really tired. Must be hungry as well because it was the fast today. But I'm very sure we are going to wind up very quickly because I myself also got tired, came just this morning from Mumbai, not very prepared. But then I realized, yes, what I need to do, I need to see that what actually exactly happens in our clinic, in our OTs, we should put it forward so that we can find some solutions for that. As exactly it happened in the previous talk as well, whereby we realize how we can manage the various situations during cesarean section. In fact, I still remember, we were at the Oasis Mall and Dr. Virkar asked me, what should I name this particular CME now? because there are all different topics, the cesarean, hysterectomy, fibroid and the micronutrients. I said you say it as the challenges, and now it's really a challenge for me as well to see that all of you get interested in this panel as well. This is our great struggle in medicine these days. It's not just with ignorance and uncertainty. It is also with the complexity, how much you have to make sure you have in your head and think about. There are 1,000 ways things can go wrong, and that we really never understand unless and until we face that. Now, I don't need to tell you what is hysterectomy, because hysterectomy is one of the very commonly done procedure, and that's why, nowadays there is a lot of inquiries about the hysterectomy as well. Rather, now we send actually the reports to the various authorities in the cities, in the metro cities, about what are the indications for the hysterectomies. Because we thought it's a very safe procedure, and even done in the young women won't affect per se anyway. But it's not so. That's why we need to understand all those complications also very much clearly. And that's why the types of hysterectomy also matters a lot when it comes to the given case. So let us start with this particular aspect itself. So I will keep all questions open to all the panelists. You can choose whatever you want to choose and speak about. There may be some controversies, I do understand, but I wanted to understand that what are your says that does type of hysterectomy matters as far as the complications are concerned?
Hello, definitely.
Yes.
It matters. What type of hysterectomy or what indication has been done, definitely it matters for the complication of the hysterectomy.
Great, yeah, sure. Anyone wants to add anything? Friends, very true that we realize that indications definitely matter, but again, the which route is best is always controversy, because it all depends on the expertise, and that's why people always feel that this particular technique is better when he or she is perfect in that. So, do you agree with this particular comment, Bhaskar, that it depends on that, the expertise?
Well, we all know vaginal hysterectomy is the safest. If I just go back to your complications, we should not be discussing subtotal hysterectomy, but subtotal hysterectomy has the least risk of ureteric or bladder injuries. We should only talk about hysterectomy and radical hysterectomy, and we know radical hysterectomy is more complications. Vaginal hysterectomy is the best. But I would say that as long as you are not doing an abdominal hysterectomy, it's good enough. Because vaginal hysterectomy is number one, difficult to learn. I think what the two reasons why people take to laparoscopic hysterectomy rather than vaginal hysterectomy. Number one, the surgeon and assistant can see a lot more. We used to get very scared of DNC. And why used to get scared? Because it is a blind procedure. So we always feel more confident where we can see something. In laparoscopy, not only the surgeon, the assistant, the nurses, the technicians, everybody. Nobody wants to go to a course for vaginal hysterectomy. But I think vaginal hysterectomy is the safest in terms of patient's recovery, complications, more and more with aging women, we'll have more medical complications, it is the best. And if not, laparoscopy. Laparoscopy basically converts an abdominal to a vaginal.
Yeah. Now I will give the situation to all of you. It's a 22-week size uterus because of fibroid. Which route will be preferred route for you? 22 weeks size fibroid, and you multiparity. Yeah. Patient is very much suitable for the hysterectomy, 45 years of age, multiparity, having a lot of symptoms because of the fibroid. So which route you will go for?
If I am expert in doing a vaginal hysterectomy, which I will agree, I will still prefer to go to a vaginal hysterectomy.
Great. Yeah. Anyone else?
It completely depends upon the expertise of the surgeon as well as the institute where you are practicing.
Yes.
If you have all the facilities to do a laparoscopic hysterectomy, then we would definitely go for laparoscopy assisted vaginal. If you have a morcellator in place, then total laparoscopic hysterectomy would also help. But that also completely
depending on the expertise of the surgeon.
Yes.
I think safety of the patient is paramount. Means don't go back from this panel, especially younger people thinking that the panel said you should not be doing abdominal hysterectomy. I think patient safety is paramount. So depending on what you are comfortable with, please do that.
Yeah, exactly. See, it was a story of 2000. Me and Dr. Kurian Joseph, we went to Ranchi to have that EMOC certification for that Ranchi Institute. And we were discussing about the same situation. And that time, Kurian was very much, rather now also is very much famous for his laparoscopic surgeries. And I confess that in such situation, always prefer to take the incision and deliver the uterus and make a very simple, clear-cut abdominal hysterectomy. And then he surprised me saying that he also does the same. Though he was a very famous, popular surgeon, laparoscopic, he said that if the size is more than above the umbilicus, always prefer to go for the open surgery because, as Bhaskar said very correctly, the safety is finally more important. Now, Monica, as you said about the morcellation, let me ask Raju that what is your opinion about the morcellation? Suppose it is laparoscopic hysterectomy with such a big fibroid. What science says about it? What people are discussing about that morcellation process?
Yeah, actually, there have been instances where the fibroid has turned out to be sarcomatous. So
Yes.
we are worried about that aspect. And although the incidence is, I would say, less than 0.1%, still we have to give that safety to the woman, and therefore it has to be in an endo bag. I think Dr. Bhaskar Pal or any laparoscopic surgeon would throw more light on it, but my take on it is, especially in large fibroids where there is a possibility of sarcomatous stage, one should do the morcellation in an endo bag.
Yeah. Yes. Anyone want to add anything?
I think number one is that in hysterectomy, always try and deliver the specimen vaginally. We are more skilled at vaginal hysterectomy than the West, and with laparoscopic hysterectomy, our actually skill of delivering large uteri vaginally has improved. There are many techniques. If I have to morcellate, I will morcellate in a bag, not because that I am worried about sarcoma. I think sarcomatous degeneration in a fibroid doesn't occur. Sarcomas are de novo tumors. So if somebody has had a fibroid for ages and coming in for surgery, I am not worried about sarcoma. I am worried about sarcoma, somebody presenting with a new fibroid, especially in an elderly age group. But the reason I will not morcellate is, as laparoscopic surgeons, we go back and see disseminated leiomyomatosis after a naked morcellation when we do a laparoscopy for some other reason. So morcellate always in a bag. I know it pushes up the cost, but try and do it always in the bag. But that is essentially for myomectomy. Most of the uteri, up to 20-22 weeks, we can deliver it vaginally if we have some space.
Yes, I would like to add that I had this case of disseminated leiomyomatosis. In fact, that was presented by, published by Dr. Nitin Shah also. And I think that is one very valid point, that is also one reason why we need to morcellate in a bag, because in that case there were fibroids all around, the omentum, even right up to the top. So, it was at least 12 different sites it was found.
Yeah.
As Bhaskar Pal sir said that delivering it vaginally, like as you said, sir, as soon as I finished my MD, I went for my fellowship in endoscopy, even though I'm practicing infertility. But my teacher, Dr. Sangpal sir, always used to do vaginal delivery of the uterus, whether it was 20 weeks or whether it was a 12-week uterus.
Yeah. Now, Rohan, see, now it's a modern medicine, and probably being the youngest and must be getting exposed to this, I wanted your opinion about this. The robotic hysterectomy, because that is a craze nowadays, and you must have seen so many posts coming up in WhatsApp that yes, now we do robotic surgery. So I just wanted to understand that what is your perception about this particular fact. I'm going to ask the same question to another young gynecologist, Dr. Chandrakant, as well. So please give your opinion that what you thought about, what is your reading says about this robotic surgery.
So what Bhaskar Pal sir said, that talk about playing on the Xbox, playing on this is just a more higher end version with a lot more actual mobility. The major advantage of your robotic surgery is that you do get a lot more degree of rotation. So what it ends up doing is, with your laparoscopy, you generally have in 4 axes. In a robotic surgery, you end up having 8 axes. So you get sort of like a wrist movement in the robotic arm, but obviously at the same time we do have to understand that you need specialized teams for this, because there is something known as docking of the robotic arms and undocking as well, which does take time. Initially I remember I used a Da Vinci back in 2012 at ASRM, where they were just making us
Practice. Yes.
lifting rings and putting it on another. Now I'm a PlayStation person myself, not an Xbox person, but it's just all about hand-eye coordination and it made it seem very simple. My mother always says that with more advancing technology, I think technique gets lost a little bit there, where laparoscopy would become easier and it becomes more accessible to all. In a way, it's a good thing. It's a shorter learning curve. I feel, Bhaskar sir may disagree with me being a much more experienced laparoscopic surgeon, but as a beginner, when I was in my MD, where I could easily function with that robot, if I tried laparoscopy at that point as compared, it would be a lot more difficult to judge the assessment. And obviously with robotic, it's 3D as compared to your 2D machines, so it again gives you a depth perception as well.
Yes.
Though robotic
Yeah.
is now expensive,
Yes.
but it gives the advantages of 360 degrees hands arms.
Correct.
That will give definitely in the pelvis. And the thing is that we can disassemble, and assembly is very costly.
Yes, yeah, very true. So probably being the technology which is still experimental per se, I'm very sure day will come that people will find that it is again another good technology as well. Now coming to the complications, the intraoperative and the post-operative, there are n number of things by which the actually things can go wrong, and that's how I came across this wonderful paper, a review article about complications of hysterectomy. But again the paper quote that the complications of hysterectomy can be categorized as infectious, venous thromboembolic, genitourinary or GI, bleeding, nerve injury and the vaginal cuff dehiscence. And then I thought, why not put actually all these scenarios in front of you to give one opinion about all these complications, and that's how we can come across. Now, I remember a case where a laparoscopic hysterectomy was done in one of the very reputed nursing home. Unfortunately, somehow there was an incidence of infection and the abdomen became full of pus, where it was then shifted to some other hospital, and there was a lot of medical legal issues happened with that. So I want to understand from all of you, what are the simple messages we can give to the beginners per se about to avoid this particular scenario, to avoid the infection? Yes. Yeah. Anyone can take, yes.
Proper sterilization,
Yes.
hand wash techniques,
Yes.
then antibiotics.
Correct.
And mostly one of our cases, after doing hysterectomy, within the 4 hours she has got fever.
Correct.
And we have sent cultures, and that was the positive culture, and she was in full-blown sepsis. We don't understand within the 4 hours how she goes to in the sepsis. That was the anesthesia complications. That was the propofol. That was the culprit for that. Propofol is the culture media, good culture media for that. If you don't use the propofol for more than 24 hours, it is better way to discard it.
Correct.
Because the bacteria will grow in that.
Yes. Monica, you want to add
Sir,
anything? Yes.
Ensuring that the patient is physically fit before doing the surgery, her nutritional status, her hemoglobin has to be in a good shape before we induce the patient. Cleaning of the abdomen, pre-surgery, clipping of hair and not shaving would also reduce the infection rate.
Yeah. Yes. You want to add? Yeah, please, Rohan.
Even sometimes when we have surgeons come in and do the surgeries, ensure that those instruments are maybe put in Sidex for the adequate amount of time and not being rushed in order to complete the surgery. Sometimes even we are in a rush, we don't realize that we may not have put the instruments for an adequate amount of time for the sterilization.
Yeah.
In the
Yes.
laparoscopic surgery, many times there is a desloughing of the tissues, and after that 4 to 5 days also patient got infection. So extended course of antibiotics is recommended
Correct.
up to 10 days.
Yeah. Yes.
Pre-operative antibiotic.
Yes. Umbrella of antibiotic.
Before the surgery. Before
Yes.
the surgery. Minimum
Yes.
4 hours before the surgery.
Correct, yeah. Let me tell you one very interesting story of this sort. When I was in Nanavati and me and Dr. Sharad Shah, we did one hysterectomy. And after hysterectomy, patients started getting fever after 4 days. Then in those days, it is story of 1985-86, ultrasound was not very popular, it was new. Someone put a probe and they found there is something shadow, echogenic shadow in the abdomen, and they thought of some foreign body. You know, Dr. Sharad Shah, one of the very renowned surgeon, he said, no, it only be possible because I always see that whatever mobs I take, whatever actually the things I use for my surgery are seen by me at the beginning as well as at the end. The patient was shifted from one to other hospital, and then eventually when it was reopened, it was an enteric perforation, which gave rise to all this, the complications and the sepsis. So sometimes we'll have to think out of box as well when it happens with the infections in pregnancy. It could not be the only surgery. There could be the other reasons as well. Because of that, it may get masked or overshadowed. And then we get a case where we find sepsis in the operated case. Could be hysterectomy, could be any other surgeries as well. The another very common disease complication is venous thromboembolism, because nowadays many of our patients are obese, and that's how actually we need to be very careful for that as well. So some simple tips to avoid the occurrence of that venous thromboembolism. What you practice, yes.
One thing is early mobilization as soon as possible.
Yes.
If they are really obese patients, then also to start low molecular weight heparin.
Correct.
Right after, I think you can start it as early as 6 hours after the surgery. So 6 or 12 hours. So that is also one thing that can be done. But I think the main thing is early mobilization.
Yes, yeah. It's very important to address this issue because quite often we forget. We find that surgery is very nicely done, it happened in a given time, and then we forget that there are so many other things. The patient is obese, so we'll have to be very careful on that particular part as well. Friends, you must be remembering once Dr. Anil Magdum had come to deliver actually a talk to our society about various complications, injuries, and he showed so many cases of, in the practice where the injuries happen to the genitourinary tract, GI tract, and I still remember me and Dr. Sardesai, we were sitting in the audience and we were discussing, oh my God, so many times, so many complications can actually happen as well, and we'll have to manage it as well. So the GU tract, the genitourinary tract injury is one of the commonly seen actually the problem with hysterectomy, especially bladder, and the second one is ureter. So what should be the role of a gynecologist whenever he finds that bladder is injured? Yes.
The thing is that you should promptly recognize that injury.
Yes.
Recognition of the injury is
very important, yeah.
Then second thing is, if we are doing vaginal hysterectomy, then bladder can be repaired from below only.
Correct.
Because that is away, injury is always away from that ureters. When doing the abdominal hysterectomy, you should track the ureteric openings.
Correct.
If the ureteric opening is very close to that injury, then you have to put a ureteric catheter.
Yes.
For safeguard the ureteric opening.
Yes, yeah. So basically what is important is to understanding that injury clear cut is that is very important, so that you can do the whatever steps you want to take, or you want to have the help of your urologist friend to see that it is properly corrected. It's very actually commonly seen that these injuries heal very fast and the complications per se. Yes, Rohan, yeah.
So one more thing, that when we suture the bladder, whether you've done it yourself or you've
called surgeon,
right? Just a thing which I learned recently was that after you finish suturing, just add methylene blue retrograde, fill the bladder to check if there are any leaks anywhere, or you've done a watertight closure or no. I had a recent case of an obstetric hysterectomy which I had done, and the bladder had opened. We knew that was a previous to LSCS. So with the urologist, we just sutured it. When we pushed the dye, we saw that there was a leak somewhere else as well. So we ended up closing it and checking it. It's just a simple thing which will ensure the patient safety and a good patient recovery as well.
Yes. And yeah. Yes, Chandrakant.
It is that electric injury. If we are using in the laparoscopy and we have cut that bladders with our cautery, then what?
I will leave that to Bhaskar sir.
Sir, if we are doing laparoscopic hysterectomy and we open the bladders with our cautery,
Cautery.
then how much part should be we?
Number one, if we open the bladder, if the bladder injury is due to an energy source, every energy source has got a lateral spread. Okay, the only time I have had a repair failed is the early days of harmonic, where we were taught that the harmonic doesn't have lateral spread. So with the harmonic, we are doing adhesive lysis and the bladder opened. We closed it in 2 layers normally the way we do. On day 14, we did a micturating cystourethrogram. It was normal. We took it out. Day 23, patient came back with a leak, and we found laterally sloughed out. So the problem is, we think that monopolar cautery or bipolar cautery gives more lateral spread. No, unfortunately, these are orphans. They don't have an industry backing them. Okay, so everything has got a lateral spread. So if there is, because of an injury, there are, now I will always suture it in 2 layers, and I always will go half to 1 centimeter lateral to the cut and suture from there.
Figure of 8 sutures. They are taking figure of 8 sutures.
I usually suture it continuous in 2 layers.
So it's very important message one should take home, that yes, whenever it happens with the cautery, whatever is seen, there is a lot of damage beyond that as well, at least few millimeters, and we'll have to think about it. So a very nice, actually, the opinion I would say, Chandrakant and Bhaskar, that every OBGYN should understand about this injury by, yes.
I just want to summarize what they said. Number one, that who should close a bladder injury? Always the gynecologist.
Yes.
But medico-legally, if your hospital has a urologist, it's a good idea to call the urologist and make the urologist stand there. Number two is, as Dr. Chandrakant said, if you are close to the ureteric orifices, I would always involve an urologist. And number three is that, as Dr. Rohan said, always inflate, be it laparoscopy, be it open, to see that it is watertight. I think that these three are essential.
Do you refashion the edges if it's a current injury?
Only if we see that the edges are ragged. If they are not ragged, I will.
Because there is a lateral spread. Do you
Yeah, but I am taking more tissue from there.
Just
from
take
the
it to the lateral side, that's all.
Yeah. Now coming to the next part, which is again important, bleeding.
I just wanted to tell you.
Yes.
When you see urologists doing a body flap, okay, or a ureteric reimplantation, they open the bladder with a cautery, and they don't refashion the bladder before suturing them. Okay.
Yeah. Now coming to the next complication, the bleeding complications, which is another thing which one should immediately recognize and do, because quite often the vessels, they retract. So any take-home messages to avoid these bleeding complications, what you do in your own cases to avoid bleeding complications. Any particular technique by which you ligate the stumps? Yes.
One general thing that can be done is give them tranexamic acid drip at the start of the surgery. 1 gram of tranexamic.
Okay, tranexamic acid, good. Yes. Yes.
The congestion and bleeding.
Yes.
For the laparoscopy, coagulate more, cut less.
Okay. Yes. Very good. And what is your opinion about the just ligation and the transfixation? What is your choice?
Transfixation.
Yeah. So what additional advantage we avail by doing the transfixing that particular stump?
I didn't get it.
What additional advantage we get?
There is a less likely to be slip that ligature which you have put.
Yes.
Less likely chance.
Less likely. Correct.
Right?
Yeah.
That is it.
Yes, very true. So this is very, very important to see whenever you feel so that when you are ligating and you have some sort of confusion, always transfix it. But when it comes to uterine, so do you take a blind actually suture for that? You want to denucleate that particular uterine artery before taking the suture?
Delinate.
Yes, delinate.
See the properly and then ligate. In
Yeah.
obstetric hysterectomy, double sutures like.
Okay, yeah. Now, coming to the next part of complete neuropathy, quite few of you probably may not think about where the things can go wrong. Any take-home messages on this particular part, the neuropathy after hysterectomy, which is rare, but have you witnessed any time? Because in my practice of 35 years, I never saw it, but when I saw in the literature, I thought it's a good opportunity for me as well to learn about it. That have you ever faced this neuropathy after hysterectomy?
We have actually. We have after laparoscopy, long laparoscopy. And it's possible to do with the stirrups and the leg being in an odd position.
Stirrups, yeah. Yeah. Anyone else?
Even say for vaginal hysterectomy take long time. It is same thing that the patient find it to even walk on the next day or a few more days.
Yeah.
But it is self-limiting usually. Rarely.
Yeah. Any one of you use the tab block nowadays to avoid the post-operative pain? And any opinion on that?
I think the tab block, I've not ever used it for a hysterectomy, I've used it for a cesarean section. But I think it works very well. The patient recovery is also much better. I've given my own wife a tab block during her delivery and she was walking 6 hours post an LSCS. So I think the recovery was good.
Yeah.
No, tab block we've used after hysterectomy. Basically, we are a DNB teaching institute and with a very busy anesthesia department. So what they get depends on what is the thesis currently on. So current thesis is on intrathecal morphine. And believe you me, intrathecal morphine, when they add that with their sensor cane, patient does not, even after a cesarean section, patient does not require a narcotic till next morning. So tab block also works well, but we've used tab blocks for hysterectomies.
Yes.
But I think what is very important is pain relief is important. It is important because I keep telling my juniors, in the post-operative period, even if you don't go and see anything, just feel the patient's pulse. A tachycardia means the patient is either bleeding or she is getting into sepsis or she is in pain. If the pain is controlled, then we know a tachycardia means there's something to worry about.
Yes. Basically, it is one of the additional and wonderful actually intervention we can say about, and many of the clinics they are using it. They always say that it has to be done with ultrasound guidance to have the perfect actually the block as well as getting the good relief. But yes, quite often we can do it blindly, but we'll have to take care of these two things, avoiding to inadvertent actually going the drug in.
Always be under ultrasound guidance.
Always ultrasound.
Yes.
Even it's our anesthetist, give it with ultrasound.
Ultrasound guidance, yeah. Yeah, but otherwise the care to avoid the vascular injury or going the drug in the vessel, one need to be very careful on that particular part. Now coming to the next, the vaginal cup dehiscence, and quite often it is because of the infection what people say about. But there is also so many papers we see whereby they used to say that keep the walls slightly open to allow the drainage, and especially in the western world is very commonly used technique. Any opinion on that particular part, the vaginal cuff and?
I don't think keeping the vault open
Yes.
prevents a dehiscence. Keeping the vault open prevents a pelvic collection.
Correct.
So basically I always, whatever hysterectomy I do, I always put an intra suture because it works like a drain. Dehiscence, older days we used to see typically between 10 to 14 days after an abdominal hysterectomy, where a patient would come into a secondary hemorrhage, which would be very severe, would pack, give antibiotics and give blood transfusion. With laparoscopic hysterectomy, it's much more common, but it is much more minor. The patient presents somewhere between 14 to 21 days with one bout of bleeding. These patients will not need a packing, these patients will not need a blood transfusion, and this is essentially to do with too much of cauterization on the vault. I like to suture my vault when there's some blood in the vault. In the initial days, you cauterize it too much you just fry the tissue because you're worried patient will bleed. And that is where dehiscence occurs. But dehiscence also occurs due to lateral spread. But in laparoscopy, the dehiscence is self-limiting. Means there's nothing to worry apart from giving them some oral antibiotics and oral tranexamic acid.
Yes. Yeah. Any opinion on that? Friends, you know that the various problems related to the appropriate authorities intervening in the hysterectomy was because of the incidents which took place in Maharashtra itself, in Marathwada, where we found that all those actually laborers who were working in the sugarcane factory, they underwent hysterectomy at a very young age. And that's how the, lot of discussion happen in the various media as well as on the various WhatsApp group, and all those restrictions started coming on that particular aspect. Now, I want to understand about these menopausal symptoms after hysterectomy. What are you saying on that? Whether you remove the ovaries or no, what you do whenever patient comes for the follow-up to understand whether she got any such type of menopausal symptoms.
In young patients, we should not remove the ovaries, but the thing is that the every patients got hysterectomized will be have the 4 to 5 years earlier menopause than that of the if she is not hysterectomized.
Correct, yeah.
I think
Yes.
that.
Yeah. Any other opinions?
So the proper counseling of the patient
Yes.
operatively that she might experience these symptoms earlier than the other patients, as well as it would be quite normal for her to have a lack of sexual desire because of the dryness. These have to be counseled pre-op so that she is mentally prepared for those changes. Secondly, in patients where we are anticipating that there could be an ovarian cause, or if she is a very high risk factor and has a family history of malignancy, whether she is BRCA1, BRCA2 positive, and we would require an oophorectomy earlier in her life, then she would be an ideal candidate to give HRT at the earlier phases.
Yes. Yeah. Any other opinion on that?
The first foremost, the basic thing as gynecologists, we should be aiming for ovarian conservation as much as possible.
Yes.
Like as she said, even after menopause, they say that up to the age of 80, the ovaries are producing some hormones which are always beneficial to the lady. So therefore, ovarian conservation should be the first thing. But yes, if there is some indication, some ovarian cysts or something like that, or as she rightly said, counseling, the patient feels that she does not want to have even that little risk of ovarian cysts or ovarian malignancy later on, you can go for a oophorectomy if she's beyond the age of 48 or 50. And these patients, we have to start HRT because their onset of menopausal symptoms is very soon after. I think within a month they start getting symptoms if you have not given them HRT.
HRT, yeah. See, basically this became very popular after Angelina, when she published that she has removed everything because of this BRCA, which Monica said very correctly. But Monica, let me ask you, what is your understanding about the BRCA? That does it give the protection completely? Suppose you do that, or is it justifiable, suppose the BRCA is positive, to remove the breast and ovaries?
People who have a very strong
Family history,
only
yes.
for those people. Randomly doing BRCA1, BRCA2 will not help for us.
Exactly, yeah. Rather, nowadays the oncologists say the same thing. They say that by doing the prophylactic oophorectomy, it reduces the risk of, getting any further malignancy in the body by 50%. Especially breast, it can give 98%, and that's why people think about it. Now, one of the very interesting article I read about that few of the surgeons, they want to preserve actually the cervix in young patients when she needed to undergo hysterectomy to avoid the sexual problems. So what is your opinion on that? Does it help anyways in the orgasm, or is it justifiable to do so?
It is not justifiable
Yes.
to give a service back for that reason, because it has been proved that there doesn't have a difference in the sexual happiness or anything like that. Therefore,
Yes.
And the cervix can be a culprit for developing a malignancy later on. Therefore, I think there is no reason that we should give back when there is no need or indication to give back the cervix.
Yes.
There was a lot of debate about that. There's a randomized controlled trial done by the current president of the Royal College, Rani Thakkar, when she was a resident.
Yes.
So we participated in the trial, and that has proved beyond doubt that keeping the cervix back has no advantage.
Correct, yeah. True. So this is again very important. I was about to address the same Rani's paper because, that in those days there was so much actually commonly kept debate in the various conferences about keeping the cervix. Now, coming to the very important last part, the pain, persistent pelvic pain, sometimes patients they come with after hysterectomy. So what you say on that? Causes, what are the preventive methods, and how to manage it? Yeah, you can take openly whatever. Someone can take the causes, someone can take the prevention part.
I think the one thing is we should not ignore it.
Yes.
Very often they keep coming back to us, and then we just give them some painkillers, or it is nothing, they don't worry, things like that. We should never ignore it. We have to, if she's coming back again and again, we should investigate, get a good sonography, if required a good MRI, to rule out any possible complications. Sometimes it could be a mop, sometimes it could be adhesions inside. So if required, if it is suggestive of something like that, we need to go in and correct that whatever is there. And other than that, of course, your usual painkillers and things like that will help.
Yes.
General surgeons many times goes for the adenolysis for the pain.
Correct, yeah.
Many times they goes.
Correct, yes,
We have
yes.
done one adhesiolysis in a patient, second look laparoscopy, and there were a lot of adhesions on that side, and we have done a adhesiolysis, and then she was relieved. So if required, it's only one case in my career, so but still, yes, if required, it needs to be done.
Yes. Anyone wants to add anything on that? And with that, let me tell you the story of Nagmani. Nagmani came to us at the age of 38 with CS cervix. She underwent Vardhan hysterectomy, and 1 month after surgery, she came with backache. I thought, yes, it could be as Raju said very correctly, we gave some analgesics and supportive medications, calcium. And second month she came absolutely bent like an old woman. And then I realized, yes, probably I'm missing something. This is the surgical menopause. There is sudden deprivation of the actually hormones in her body. And then we need to intervene with the help of our orthopedic surgeon to see that how we can correct her osteoporosis. And challenge was how to manage with, not giving estrogens, because she has undergone hysterectomy for the malignancy of the genital tract. And then we don't want to put actually her for the risk of again having the breast cancer. And then we thought, let us try with the combination of raloxifene, calcium and vitamin D3. And to our surprise, she responded to that and she became a little better after that. So friends, it's very, very important to understand all these complications in detail whenever we are subjecting our patients for the hysterectomy. And we'll have to see that all those things which you can see here as the symptoms need to be addressed very, very clearly. Because all said and done, what is important is support, which is essential in any particular surgical condition. We can definitely manage the things very properly. So thank you very much, friends. I understand it's almost coming to the 11 p.m. I'm not wrong, and I can see the faces tired so much. But with proper strategy and tactics can optimize the result and bridge the gap in the surgical management. What very nicely quoted for. Thank you very much, panelists, for giving such a practical tips for all those complications which are very common in day-to-day practice. But we need to adopt actually this particular attitude whenever we are managing our cases surgically. Thank you, and thank you to Solapur OBGYN Society for giving this another opportunity, which probably one day they will say, no, Milind, you stop speaking, you speak so much in every event. So that's how, Virka, thank you very much. Meena, thank you, and all other office bearers. Thank you, thanks a lot. Yeah.
I request President, sir.
I just wanted to share one recent case. It was a previous to LSCS, and laparoscopic surgery was done. The surgeon was, I don't do it, so I called somebody. So she said, this time the adhesions are not very, they were not very thick adhesions, so she proceeded with the surgery easily. But on the 4th day she started leaking. So when it is so early, it is most likely to be ureteric. So subsequently we called a urologist, and he was able to put in a ureteric stent. And that is, so I just wanted to share this, that conservative approach can be useful. You don't have to, so he put in the ureteric stent, and even after the stent she was having leaking. So he said that it is probably a reflux which is happening because the uretrovesical valve doesn't function so easily. But then we persisted, we cajoled her, we said nothing, just wait, and finally now she's dry. And then we have removed the stent also, and it's fine. 6 weeks.
Yeah, 6 weeks of training.
Yeah, otherwise the only option was a bowel reflux. So, yeah. At least 10 friends and gather as much support as possible.
And because I was looking at the faces, now they will say, okay, stop. And I forgot to give this appeal. You know, friends, Bhaskar and me are friends since years. I remember since our IAG days and the SOGS. He's a wonderful person, good academician, and basically is very open about his opinion. That is very important, what Foxy needs nowadays. With so many scenarios which are coming up, as happened with the hysterectomy as well. So I'm very sure, Bhaskar, you will have a very long way to go and you will get support from the all societies, not only Solapur Society. We wish you all the best, and I'm sure it will be useful for the entire Foxian clan. Thank you.
Dr. Chandrakant.
Chairperson Dr. Madhuri Madam, Dr. Rogoji Madam, and today's speaker Dr. Rohan Palshetkar, Dr. Rajendra Nagarkatti Sir, Dr. Bhaskar Pal Sir, panel moderator Dr. Mirin Shah Sir, and panelists Dr. Sulbha Zamne Madam, Dr. Monika Umardan, and Dr. Chandrakant Jadhav Sir. Thank you, Meyer Pharma, our education partner.
Thank you.
For
Thank you.
sponsoring today's